welcome back to the last portion of our Minority Health Summit here at blackdoctor.org. It's been a great evening so far, and if you have missed any of the previous panels, I suggest you go check those out. But I am your host, Shamika Rhymes, and I'm so glad that you're joining us. Please let us know where you're watching from. Drop your city or state in the chat. And since April is National STI Awareness Month, we're shining a light on the importance of sexual health, stigma, and education, especially in our communities, where silence around these topics often leads to serious consequences. And so tonight, I am joined by an incredible panel of experts who are committed to shifting that narrative. So first up, we've got Dr. Keith Crawford. He's currently a program officer in the Therapeutic Research Program in Division of AIDS at the National Institutes of Allergy and Infectious Diseases. Hi, Keith.
Hello. Thank you so much for having me. And I'll just make a statement that any comments that I make are my professional opinion and do not reflect the views of the National Institutes of Health.
Thank you for that. Next up, we've got Dr. Nisochi. She is an internal medicine physician, and she is also a civil surgeon designated by the United States Department of Homeland Security and the United States Citizenship and Immigration Services. And she's the CEO of the Internal Medicine Private Practice, Dr. Nisochi, LLC, and health media consulting company, Supermodel MD, LLC. Welcome.
Thank you so much for having me. It's a pleasure to be here.
Thank you. It's so good to see you. And Dr. Chandra Adams is here. She's an OBGYN and women's healthcare economist. She works closely with midwives and has her own practice, Full Circle Women's Care in Jacksonville, Florida. Welcome.
Thank you so much.
I'm excited to get into this conversation because we're going to talk about the most common STIs affecting our community, why the stigma still persists, and how we can start having better, braver conversations around testing, prevention, and healing. So those of you in the chat, make sure you hit that share button so that everybody on your feeds can check this out as well, and invite somebody into the conversation, into the chat. So, and make sure as we go along this evening, if you have any questions, drop it in the chat, because we want to make sure this is a safe, honest place where you feel free to ask those questions that you have lingering in the back of your mind. So with that being said, Dr. Crawford, why is STI Awareness Month so important, particularly for communities of color?
Well, one of the things is that STIs can be diagnosed and treated. These are sexually transmitted infections. Again, they can be spread to other individuals. They are transmissible. So that makes them a concern. If they're not diagnosed and they're not treated, they can cause serious complications. And some of these complications can damage your reproductive tract. So you may have plans on having a family at some point, and because of an untreated sexually transmitted infection, you may not be able to, as a result of damage to your reproductive tract. But there are many other types of sexually transmitted infections. For example, hepatitis B virus could infect your liver and could potentially lead to cirrhosis or liver cancer. Human papillomavirus can cause cervical cancers and penile cancers and anal cancers. So these are things that can be treated and they can be prevented, and they're common. So we need to know about them. We need to talk about them. We need to get screened for them so that they can be recognized and treated, and also learn how to prevent them.
Mm-hmm. That's absolutely right. Dr. Adams, what are those most common STIs affecting Black and Brown communities today? And are those rates rising or are they falling?
So specifically, we used to screen everyone annually automatically with your pap test for gonorrhea, chlamydia, trichomonas, and then you could also send them out for the blood tests, for serology, for hepatitis, as Dr. Crawford mentioned, HIV, syphilis. And now we're doing a lot more screening for mycoplasma. But a few years back, insurance companies changed the fact that they will not cover routine STI screening with the PAP for anyone who's over 25. And that was a terrible blow to those of us giving primary care. And then on top of that, we spaced out the PAPs. So people are now getting PAP tests every 3 to 5 years. So those who normally would have been getting routine screening for things that may not have symptoms now are in a position where they're not getting screened. And so as a result of that and some of those other environmental factors, the rates are actually rising instead of falling.
Thank you. Do either of the other doctors want to weigh in on that, what those common STIs and about the rates rising or falling?
So I can weigh in on that. So in regards to some of these sexually transmitted infections, I think it's key to note there are significant disparities and research that has been done on the disparities in Black communities versus in white communities. And there is some very great CDC data that I have from 2018. So for example, in 2018, the rate reported for chlamydia amongst Black females was 5 times the rate of that of white females. In regards to gonorrhea, for just Blacks in general, it was 7.7 times higher in Blacks than in whites. When it came to the data on HIV in 2018, of the 37,968 cases of new HIV cases, 42% of those new cases were attributed to Black individuals. Black individuals accounted for that. So there are these significant disparities, and it's not getting any better when we look into this data for the disparities amongst our counterparts. So that is a significant problem that needs to be addressed moving forward.
And if I could just add, as the doctor just mentioned, these disparities are striking. They're actually found not just in Black communities, but also Latinx communities, indigenous communities, and Native American. All of these communities have higher rates of sexually transmitted infections than white communities do. And we can talk some of the reasons why we have these disparities, but I want to go back to something quickly that Dr. Adams mentioned, is that many of these diseases or these infections are asymptomatic. Many of the bacterial sexually transmitted infections like gonorrhea, like chlamydia, like syphilis, there may be signs and symptoms. There may be a urethral discharge. There may be a cervical discharge. There may be other signs and symptoms that you have, burning with urination or things of that sort. But oftentimes there aren't. It's very common for women to have some of these bacterial STIs and not have symptoms. It's also common for men to have these infections and not have symptoms. And just to give you a quick example, about a decade ago, we were doing a study in Nigeria, 2 very large cities in Nigeria, and we were following a group of men, and we were doing regular screening, and we can talk about some of the methods that we used. 70% of the infections that we detected were asymptomatic. That's a huge number. So you can have this, you may not be aware of it, you're spreading it to other people potentially, and you could potentially do harm to yourself. So it's important to be in care and to know where you can get regular screenings.
Yeah, thank you. And this question kind of goes for all of you, but why does that stigma still exist and persist in our communities around STIs? I don't know how many times I've logged on social media and I've seen people shaming those for having an STI or who they assume has an STI because maybe a picture they posted, they think, oh, there's a bump right there on their lip, or that's got to be what that is, or you know what I'm saying? So how does that those conversations and the stigma affect testing and treatment. Who wants to
It's part
tackle
of
that
it. I
one?
mean, it's just some of the taboo surrounding sex in general. It's just what kind of person are you? If you're, the thought really is that STIs are associated with promiscuity, and
Mhm.
there is shaming for having multiple partners, and even and I tell people, I'm like, you're not doing anything different than anybody else is doing. It's just
Mhm.
something happened to you when you happened to do it, and it was that you were with a partner who may or may not have known that he or she had this infection, and they spread it to you. But it's just devastating because people don't want to be thought of as loose or as not having these high morals and not clean, which is it's unfortunate in terms of the fact that people then begin to judge themselves and may not seek care or treatment because of shame.
Yeah.
I think that also, I don't know to what extent we learn about these sexually transmitted infections as part of physical education in school. I can remember when I was in school, and believe me, you do not want to know how long ago that was. It was a very long time ago. But we learned about sexually transmitted infections. So I think teaching this to children in schools is one way that we can start to target the stigma. I think the other way is the more that we normalize this as routine screening, when you go in to see your physician or nurse practitioner, whoever you're getting your care from, they should be asking you about are you sexually active?
Mhm.
If you're not, do you want to be? Are there some issue? Because there could be some medical problems that could be affecting your libido or whatever the case may be. But uh, the screening should be routine. And when your provider asks you, they should be asking, okay, we know the genitals are involved in sex, but
Mhm.
there are other parts of the body that are involved in sex too. So people, we use our mouths. We may use our rectum. We may use other parts of the body. All of these need to be screened. So your provider should be asking when they get ready to do a screen, okay, I'm going to collect a urine sample. Do I need to do a throat swab? Do I need to do a rectal swab? Do I need to collect a sample from other parts of your body that could potentially be harboring an infection that we can screen for? And another reason why it's important is that some parts of the body may need more medication. We may have to treat with higher doses. For example, if someone has gonorrhea in the throat, we may need to use higher doses or treat for longer. Again, these are things that can be determined that you need to discuss. But the first thing is we need to know that it's there. So
Mhm.
your provider should be asking you about screening. And if they don't ask, then you need to tell them.
Mhm.
Dr. Crawford, so I do have a question because I also was in school in the 1900s. When they taught about STIs when you were in school, was the messaging behind it more of a so don't have sex? Or was it but so if you have sex, here's how to protect yourself?
Yeah. So from what I can remember, and I'm thinking back a long way, um, it wasn't so. The advice was no, you shouldn't have sex. But if you do,
Mhm.
if you experience this, if this happens, you know, go and talk to some, which is often difficult because, you know, the children may not want to make their parents aware of it. Talk to a school nurse or
Mhm.
talk to a teacher or someone who can get you help and get you screened. So that was kind of the messaging that we got.
Oh, thank you. I too went to school in the 1900s, so I think we had the same the same education.
Well, something I actually wanted to buttress off of what Dr. Adams mentioned in regards to the sources
Sure.
of some of the stigma. So an
Mhm.
important thing that you did mention, Dr. Adams, which is key, the societal norms and values. Essentially now in society, there are all these negative attitudes towards sexuality, especially those surrounding relationships that are not monogamous. So there's a lot of shame associated with those kinds of relationships. And we have to think about media representation as well. That's another source of the shame, the way that the media actually portrays sexually transmitted infections. It's always negative, it's always shaming. It's never really shining a light on what needs to be done and the positive aspects of how one can move forward to really empower themselves with the tools to treat and move forward with living their best life. And I think another source of shame, just past personal experiences. So if you have seen another individual, a family member, a friend who has had a sexually transmitted infection, think about how that person has been treated or what other individuals had to say about them. So when you think about that, it's typically negative rhetoric surrounding those individuals. So one is not really motivated to move forward with really doing what they need to do to prevent, to treat if need be, or to have those important discussions. So the sources of stigma still exist, and there still needs to be a way to circumvent some of these things that we continue to see as a source.
Mhm. I wanted to ask you, since you're bringing up like media and culture and past experiences, what about churches and faith? What do you think about that and religion and how it plays a part?
Yeah, so depending upon one's faith, if they're extremely religious, sometimes you'll hear based upon their faith, any kind of sexual activity that occurs premaritally, so premarital sex, is deemed impure sex. And some may think or may deem sexually transmitted infections as potentially punishment for engaging in that kind of activity before marriage. So those kinds of things can also impact as well that kind of stigma surrounding sexually transmitted infections.
Right. And
Okay.
when the message that you're getting all the time is don't do it, don't do it, don't do it, then how do you come forward with I need to be screened for it? Because you have to back all the way up to I know I'm not supposed to be doing it, but I did it. And so
Right.
now I need to be screened for this thing that you may view as a punishment. You're absolutely right, Doc.
Mhm. Yeah. So how do we shift that narrative of all the stigma from whether it's the media, faith that we just talked about, past experiences and culture, just all of it? How do we begin to shift that? Because it's a lot of different things.
I think conversations like this are a good start.
Mhm.
Just putting out there what the actual conditions are, what some of the repercussions are, because people tend to people tend to buy into more the victim side of it versus the judgment side of it. So, as Dr. Crawford said in the beginning, so for a patient who's had chlamydia that was undiagnosed for however many months, and now her fallopian tubes are scarred and she's not able to have children, no one's judging her now because she is a victim. Or the patient who had pelvic inflammatory disease and now she has chronic pelvic pain and has to have a hysterectomy or has to go through fertility treatments or anything like that. You don't focus so much on the story of how it happened because you're like, oh my gosh, this terrible thing happened to this wonderful woman, and she's now the victim. So I think kind of changing the narrative of people being the villain, and changing it more to them being the victim, because everybody has a sympathetic place in their heart for the victim versus the villain.
I think people might consider, at least in classrooms with students, maybe forming peer groups and
Mhm.
peer groups with girls, peer groups with boys, create scenarios and discuss these scenarios and create standing peer groups, create networks where people have a safe place. People don't stigmatize as much. People become part of a network and start talking more openly. That may translate into better outcomes when people, find themselves in a situation where they may need to go get help. Plus, they're better informed. They know where they can go and get help. That might be a possible contribution to the solution.
Mm-hmm.
Tell the influencers. They tell all of these young people what to do and how to act, because I'm seeing now, because I take care of mamas and babies. These girls now are saying, no, I want a doula, I want a postpartum doula, I want a night nurse. Like, they have this whole list of things that I'm like, why wasn't I smart enough to ask for those things ahead of time? But I bet you, if there is a campaign, let me see your test results, because testing is key. Communication is good too, but you want to know that the partner who you're with values you enough to be tested before they become intimate with you. And I bet you, if young ladies start demanding to see these clear tests before they become intimate, that's going to be a new standard.
Mm-hmm.
I think also something that's important as well, just providing support and resources. Education is really key. And from what I've seen from past sex education courses that are available, there's really a huge focus on prevention. And yes, prevention is key. And we should focus on prevention, but we should also empower individuals with information about treatment. Because there's just this focus on, practice safe sex and you'll be okay, you'll be fine, you'll minimize the risk of all these infections. But the reality is not everyone is partaking in safe sex practices. So what actually happens when one is faced with that situation where they might have had unprotected sex, and now they may potentially be faced with a potential STI? So with that focus solely on prevention, that sometimes even stigmatizes one to think, okay, if I do have an STI, now I'm a pariah in society. What should I do next? So I think that patient education needs to come with a focus on treatment. What do I do after I have an exposure? Should I go get a test? Should I go and make sure that I'm treated accordingly after testing if it is positive? And if I do test positive for any kind of infection. And I think another key thing for anyone listening out there is finding a healthcare provider, whether it's a doctor, nurse practitioner, or otherwise, that you essentially trust. So many patients that I've come across, they are kind of reluctant to go to doctors initially, and there's just this inherent distrust sometimes with the medical profession. They may also think that they are being judged. So if they've had these unprotected sexual exposures, they might think, okay, what is this doctor going to think about me? So we need to really create this environment in the medical community, in our visits with our patients, that they understand that it is a safe place for them to really get the help that they need. For me, I'm a PCP, a primary care doctor, so I try to make it easy for my patients. So when they are coming in for their annual checkup, I'm ensuring that we are hitting all the preventive health metrics, meaning that we are incorporating sexually transmitted infection testing. So I offer it to all patients, and we broach that topic and have that open and candid discussion so that they have that opportunity to voice any concerns or questions that they have. And I think that is quite helpful when it comes to that. So we really need to make it such that patients are not afraid to broach the topic and talk candidly about any of their concerns when it comes to their sexual health.
Thank you for bringing that up. It's like you read my mind. I was thinking we should talk about the trust issue, because we just talked about it in another panel. But I think you hit the nail on the head, that there's a lot of people that they have trust issues because of maybe a past experience with a doctor. And so it's this fear of, okay, how do I go into a doctor's office, urgent care, wherever they decide to go and get tested? So thank you for bringing that up, because I was literally just thinking about it. And then you said it and I was like, yes.
I think the topic of treatment, and thank you so much, doctor, for bringing that up, is really key. And the trust, it's important that when a patient is given a diagnosis and prescribed treatment, that treatment is followed as it's prescribed, because these are infections, which means they're living things too. And one of the problems that we have with treating infections is that infections can develop resistance when you don't take the medication as it's prescribed. That organism, that bacteria or virus, whatever it may be, can develop resistance, which means that those medications no longer work or no longer are effective. And this has been a tremendous problem with gonorrhea, for example, and drug resistant gonorrhea. The fear that resistant strains could emerge, that we may not have really good antibiotics to treat. This has been a problem, and it's actually driven the way that we manage people who are diagnosed with gonorrhea. We don't give an oral medication. We used to write a prescription. Okay, go home, take this. You give someone ciprofloxacin or another type of antibiotic, you take it. We don't do that anymore because of problems with resistance. So you get an injection, and the single injection is administered by a medical provider. And that injection will last long enough to cure the infection. But one of the reasons why we often get resistance to these different drugs is because they're not taken properly. And this happens with HIV. It could happen with hepatitis B, because these are sexually transmitted infections that require treatment for life. You will be on these medications the rest of your life. Now, we are doing a lot of research to try to cure, expanding cures for hepatitis B, expanding or developing cures for HIV. But you'll be on these medications, so you really, really, really have to stick to the regimens. And we're making treatments easier. We have treatments for HIV, which can also be used to prevent HIV, that are an injection. One injection is given every 6 months. Now, that has to be combined with another medication, because we usually give multiple medications when we treat HIV, 2 to 3 different medications, and the same thing for hepatitis B. But we are making it easier and easier for patients to take their medications, so they don't have to worry about forgetting, or they can travel, they can go on vacation, not have to worry about missing any of their doses. And hopefully soon we will have a cure for some of these infections, but we're not quite there yet, but we're seeing some glimmers of hope.
And I wanted to just add on to that too, about making treatment easier. Expedited partner treatment is something that we don't always know is, well, our patients don't always know is available. They'll say, well, I tested positive for this, I'm getting treated for this, but my partner doesn't have a doctor, so they're not going to be treated. And you tell them, well, you need to abstain for this amount of time, and your partner needs to be treated too. And they go and tell their partner, and their partner will say, yeah, I definitely got treated. And they didn't, because they don't have a doctor, or they're embarrassed to go and say to whatever doctor they have that they need to be treated for this. But the law allows a provider to treat their patient as well as the patient's partner, so that they can stop reinfecting each other. And when they come back for that test of cure and they still have it, then you're wondering, like Dr. Keith was just saying, is it resistance or is it reinfection?
Yeah. I wanted to talk. I think, Dr. Adams, you mentioned it earlier, but Dr. Nisochi, since you were talking about stigmas earlier, I thought I would start with you on this one. But what role does language play in perpetuating stigmas, like saying clean versus tested? And we were also just talking backstage a minute ago about STD versus STI. So can you talk a little bit about that, and then we can go around and hear from everyone?
Yeah. So when we talk about sexually transmitted infections, there's usually not language surrounding it that promotes inclusivity and respect in general. So just by one saying, "Oh, I'm clean," there's that basic kind of thought process that if you say clean, then if somebody were to have a positive test, then is that person quote unquote dirty? So it insinuates that any individual that has a test that's positive for any sexually transmitted infection is by virtue quote unquote dirty, if we use that kind of language or rhetoric stating that, oh, I'm clean for the sexually transmitted infection. So language really needs to change because when you hear those kinds of terms being used and thrown around, it actually fosters a sense of shame surrounding sexually transmitted infections. It lowers the likelihood that one would even want to move forward with even getting tested or getting treatment just by fear of what it means for them to have that connotation surrounding them.
I love that we changed the abbreviation from STD to STI, because when you reinvent and represent things to people, it can contribute to that changing of the connotation of the word. So we did used to call STIs STDs, sexually transmitted diseases. And with the adoption of this new terminology, it's clicked in certain people's brains. Oh, well, no, I didn't have an STD. I had an STI. And whatever gets you to the healthcare professional that gets you treated, whatever gets you out to be tested is just fine. But if in some people's minds, there's a delineation between one and the other, and really it's just trying to make our language more inclusive, as Dr. Nisochi was saying.
Mm-hmm.
Yeah, well, in the HIV field, there has been a strong push by advocates focusing on language. So we don't say that someone is infected with HIV. We say that this is a person living with HIV, to add a more positive connotation to it. And then when we talk about individuals and other groups that are at high risk, for example, people who used to use the term addict. We used to say someone's a heroin addict or someone's addicted. We don't use that language anymore. We say someone has a substance use order. Substance use disorder. Instead of saying an addict. So we're not going to say, oh, he's a heroin addict. We're going to say this person has an opiate use disorder or alcohol use disorder, which means that there is a problem with how this person manages the use of this particular drug or recreational drug, and that it needs to be managed, and they may have to go to treatment and may require medication to help manage it. So all of these things are designed to keep people engaged in care, to reinforce their humanity as we go through the process of getting them the care that they need and getting them in a stable situation.
Thank you. Dr. Adams, you mentioned about the partner testing, but how can individuals talk with their partners about STIs and testing without that fear and that blame and the shame and all the myriad of emotions that come with it?
That's a hard one. So when they're first diagnosed, usually it is with their current partner. And so it's a conversation, one, I try to make my patients feel comfortable. I use a little humor. I say, look, I don't want to see you on the 6 o'clock news tonight. Don't go home, burning the house down or anything. And, I'll get them to laugh a little bit. But, sometimes in the back of their minds, they kind of knew maybe something was off with their relationship. And sometimes you say it and you're trying to broach the subject. You're like, hey, girl, I'm really sorry. He might not be doing. And she's like, ooh, actually, it was me. And then you're like, oh, okay, I guess it could be anybody. But if, usually for things like gonorrhea, chlamydia, trichomonas, you can write a prescription and they're cleared. When they're diagnosed with something that is an infection of chronic management, like herpes, for example, then you kind of start to see, the walls crumble. People sort of fall apart because they know, all right, yes, I'm with this partner and I have this problem and I make it out of this relationship, but this is an infection that's going to follow me, and I'm going to have conversations with my future partners, and I don't want them to judge me based on having this diagnosis already. That's a tough conversation to have, and I tell them, listen, again, it's really all about your self-worth and being with a partner who respects you enough to look past what your medical history is. It's about you getting education about perhaps being on suppressive medications and having a conversation with them about you doing everything you can do to not pass the infection to them as well. But it is there's emotional trauma associated with some of these diagnoses.
Mm-hmm. Thank you. Did either of you want to weigh in on this as well about that talk? Yeah. Okay.
So having that talk, that can be a huge source of anxiety for any individual, especially when they have a new relationship and they have not initiated sexual activity and they want to kind of find out where their partner is in regards to testing. So what I typically recommend to my patients, I have them come in to have their preventive health evaluation. So with a preventive health evaluation, you're getting screened for other things outside of just sexually transmitted infections. So you're screened for diabetes, cholesterol issues. So what I tell them after we have all our results, you can broach the topic with your partner and say, hey, I just went and saw my primary care doctor. I did my annual checkup. Part of that, I was screened for diabetes. I don't have diabetes. I don't have prediabetes. I don't have cholesterol problems. I don't have cholesterol issues. I was screened for sexually transmitted infections, and I do not have any sexually transmitted infections. When was the last time you were tested? Have you ever had a sexually transmitted infection? Where are you with testing if we are going to move forward with any form of sexual activity? So you can kind of use that as a segue to kind of see, when was the last time they were evaluated by any doctor, and if they actually have been tested in the past or plan to test so that you can move forward safely with sexual activity.
If I could just follow that really very important comment, because I think this helps us to kind of understand one of the factors why there are disparities in higher rates of sexually transmitted infections among minority groups and certainly African Americans. And we have to look at our networks. We have one set of issues which we call these structural determinants of health, and we can come back to that later. But there are also issues with our sexual networks. And when I say networks, these are the people that you're going to interact with. These are the people you're going to be having sex with. And you may not be in a high-risk group yourself. You may be monogamous, or you may, have certain patterns that don't put you at high risk. But if your partner has multiple partners, then that also puts you at risk. You're just dealing with a single person, but because that person is from a high risk group. That person may have a substance use disorder. That person may be having sex for compensation or a commercial. So you're not doing it, but because your partner. And so this is something that we see more often in our communities, that even if that person isn't engaged in high risk behavior themselves, their partner is, which puts them at higher risk.
What's the best way to address that STI stigma among young people versus older adults? Because I'm wondering if there's a separate conversation or if it's kind of the same conversation. Dr. Adams, I'll start with you.
It's a different conversation because with our older adults, when they were the age of the younger ones, the worst thing you could get was pregnant. And so when my older patients now they've gone through menopause, they're like, I can't get pregnant anymore. So, the world is my oyster. And they're out there, grandma's out there. And so when her pap comes back with this with this STI and you call to explain it to her, well, she was married, for 40 years and never thought about any of this with Mr. Charlie. And now I'm in the retirement home and, Mr. Herbert is, knocking on doors all around the home. And so things are spreading now that she really didn't worry about before. And so she's not even aware of what this is. She doesn't know any of the implications of it. So you are really going back and having, the very basic beginning conversation a lot of times with patients who you expect, age and wisdom that they've already heard some of these things. And I'll step out and say as a healthcare provider now, as I've gotten older, it's probably gotten easier. But when I, was first practicing, I'm 30 and I'm telling somebody who could be my grandmother, we got to treat your trichomonas, Miss Jackson, and it was uncomfortable for me, and that may have made it uncomfortable for her too. I think probably getting older in the field now, I'm kind of the cool auntie. So talking to my college age students or my young teens who are becoming sexually active, there are things that they'll open up and tell me that they wouldn't want to tell their mother, their parent. They'll say, all right, Dr. A, if I tell you this, does my mom have to know? And I tell them, well, no, I can't tell them anything that you tell me, but she is going to get the bill for this STI testing, if you do it today. So, it's a different conversation because I do think that the information is out there now because it's being taught in our health classes and talked about in forums like this. So we're not having to start from the same place we are with our older community.
Absolutely. Dr. Nasochi, if someone is newly diagnosed with an STI, what would you want them to know first?
First, I would want them to know that it is not a death sentence. Oftentimes, patients may believe that any new diagnosis is in fact a death sentence and life is over and it's just doomsday. So I need to empower any individual that is just newly diagnosed with any sexually transmitted infection. I need to let them know, this is what the treatment course is going to look like. This is what you need to adhere to get adequately treated. Do we need to retest you to have surveillance per se to see if we've actually adequately treated the infection? And then I need to ensure that they are not only getting treated, but they are having the important discussion with their partner to let their partners know about the infection so there is not a continuous spread of infection throughout communities. So I think that's the key piece, empowering them with the tools to know about treatment and empowering them with how to initiate that discussion, because that's a really scary kind of topic to broach. If someone is newly diagnosed, okay, how am I going to go tell my partner this? And I actually see a lot of that apprehension more so in older patients, believe it or not, because older patients who they say, oh, I've been married to my husband for 20, 30, 40 years. Why do I even need this test? And when we do a test and, guess what? There's something that does come up positive in the sexually transmitted infection panel. They're like, oh no, what happened? Who did this? I've been, faithful to my husband for God knows how long. Did he give this to me? How did this happen? Where do I go from here? Do I have to tell him? What should I do? So we have that discussion. This is what needs to happen in regards to treatment. You need to have that important discussion with your husband, your wife, your partner, whomever, about this diagnosis and what they need to do next to ensure that they are well taken care of moving forward and infection does not spread.
Thank you. Thank you. Dr. Crawford, what are the top 2 things that people can do to protect their sexual health and reduce stigma in their circles?
So I would say one of the things, and I'm going to go back to a word that we mentioned earlier, and that word is prevention. And there are tools that we can use to prevent sexually transmitted infections, and there are different types of tools. Um, Condoms do work. There are what we call male condoms that the man puts on his penis. There's what we call female condoms that the woman can insert in the vagina. So there are different types of condoms that you can try, and you can see what works well for you. There are some vaccines that can prevent sexually transmitted infections. And this is something you need to talk about with your provider. The human papillomavirus vaccine can prevent the viruses that cause genital warts. They can prevent the viruses that can cause, or most of the viruses that could cause cervical cancer or penile cancer or anal cancer. The hepatitis B vaccine can prevent hepatitis infection that could potentially lead to diagnosis of cirrhosis or liver cancer. So these are some tools that you can use for prevention of vaccines. We have tools called PrEP, which is pre-exposure prophylaxis, which can prevent HIV infection. They work in men. They work in women. They work in heterosexuals. They work in homosexuals. Whatever kind of sexual you are, we've done the studies that show that they work. You can take pills. You can get an injection. You can take pills every day. You can get an injection once every 6 months. So there are ways that we can protect. And one of the things that we're looking at now is an intervention that targets bacterial sexually transmitted infections. That would be syphilis, chlamydia, gonorrhea. It's a procedure called doxy-PEP. PEP means post-exposure prophylaxis. So this is after you've had sex and may have been exposed. It's called doxy-PEP because the antibiotic that is used is called doxycycline. And doxycycline is a broad spectrum antibiotic, which means it can target different organisms. And so if a person has a sexual encounter, forgot to use a condom or didn't intend to use a condom, whatever the case may be, they don't know whether they're infected or not. They could take a single dose of doxycycline within 72 hours. And this can reduce your chances of contracting syphilis, gonorrhea, chlamydia. All three of these bacterial sexually transmitted infections, you can reduce your risk through this procedure. Now, this is not ready for prime time yet, but it's been studied in multiple clinical trials, and it seems like it could potentially be a benefit. So the first thing that I would say is that they need to know what do we have that can protect and prevent. What's the whole armamentarium that we have that can protect us? The second thing would be regular screening. And I think both of our other panelists have talked about and given examples with their patients, the importance of screening. Remember, many of these infections are going to be asymptomatic. So being screened to detect, and then the treatment, as one of our doctors has talked so much about. So regular screening, knowing how to prevent, that would be that would be the two things that I would think people should know. One last thing I will quickly say. We throw this around a lot. We talk about, talk to your medical provider. Ask your medical provider this. When I was doing a lot of the panels and we were in the midst of the COVID pandemic, and, we were talking about, okay, if you get, call your provider, ask for a Paxlovid prescription. Some people don't have providers, especially in our community. They don't go to, well, when I go in for a physical, they're not going to a physical because they don't have a regular provider. What you should do is contact your local health department. And we're all in different parts of the country, so maybe we can chime in and talk a little bit about that. But contact your health department and find out where you can get care, because most major cities have free clinics that you can go, you can get tested, you can get treated. In most instances, you can get treated for free if you're diagnosed. So public health clinics can help if you don't have a regular provider, or, as was mentioned earlier, a trusted provider that you can talk to.
Thank you. That everything you said was super important. Thank you. And as we are wrapping up, gosh, time has gone by so fast. As we are wrapping up, I want to get each of you to just, what is one thing you want to leave with our viewers, especially like whether it's about STIs or the stigma that's surrounding it. Dr. Nasochi, I'm going to start with you.
Yeah, so a few things to leave in regards to the topic. One, regular testing and screening, as mentioned before, that is key. Second thing, having open communication with not only the healthcare practitioners, but those in your life that you are engaged in sexual activity with. You need to have that level of comfort to have these very open and honest discussions about your sexual health. Third thing to make mention of, ensuring that you understand, even in the event that you were to have a sexually transmitted infection, it is not a death sentence. If that were to be the case, have that important discussion with your doctor about the way forward. What's the overall plan? What's the treatment? What's the course of care? And what is the outlook, so that you can still have a healthy sexual life moving forward? So those are really the keys to take away from all of this.
If I had a message to leave, it would be that prevention, screening, and treating is self-care. There is a lot of talk about getting diagnosed if you have PCOS, get diagnosed if you have fibroids, get diagnosed if you have endometriosis, because you don't know what effect these things will have on your overall health picture long term. This is self-care too. So doing things to prevent the spread of STIs, getting screened regularly for STIs, and then getting early treatment is self-care. And knowing your own personal status, and then making anyone with whom you're going to be intimate respect you enough to give you an honest answer about their personal status before you become intimate is also self-care.
Yes. Dr. Crawford.
So some STIs can be cured with a single injection, and some can't. Some are potentially fatal. But as has already been said, they are chronic, manageable diseases when you are in care. I started doing work at the height of the beginning of the HIV, the AIDS epidemic, where a diagnosis was almost definitely a death sentence. That is no longer the case. That is no longer the case for hepatitis B. That is no longer the case for a person diagnosed with cervical cancer. If it's through the screening that Dr. Adams talked about, it's detected, it can be treated. So the worst of these sexual transmitted diseases can be managed. Some of them may not be able to be cured, but some of them can be managed. Many others can be cured. So if you are sexually active, that is a normal part of your life. Part of your quality of life is having sexual experiences with people that you want to be involved with. So that's the first thing. This is normal. You're not a bad person because you want to have sex, but that's what many of us have been told. And we talked earlier about, religion, the Bible, and, you're going to go to hell if you're not, let's put all of that aside for this discussion. This is Easter weekend, so this is a weekend of forgiveness. So whatever you've done that you might not feel that great about, you are forgiven. You are forgiven for whatever it is. So, but be considerate of other people and be considerate of yourself, and get care and get treated, and have regular screenings.
Yes, you all have been so amazing. And I think no one had questions because you guys gave such an amazing wealth of information. We covered all the bases and actually got through all the questions. And so thank you for coming and being a part of our Minority Health Summit. This has been amazing. Thank you.
Thank you so much.
For more information on sexually transmitted infections, you can also head over to blackdoctor.org. There's lots of articles and resources there. Again, thank you all for tuning in for our Minority Health Summit. And if you've missed any of the amazing panels that we've had today, they are still available to watch on Facebook and YouTube. So again, thank you to this amazing panel, and have a great Easter and a great night. You're forgiven. Don't forget that.
Thank you. And read